Hello, this lecture will cover disruptive impulse control and conduct disorders. These are disorders that really circulate around problematic behaviors or disruptive behaviors as a key characteristic. The first disorder to present across this spectrum of disruptive behaviors is oppositional defiant disorder, referred to as ODD. This is characterized by an ongoing pattern of uncooperative, defiant, and hostile behavior towards authority figures that seriously interferes with a child's day-to-day functioning. Symptoms would present for at least 6 months to make diagnosis. For children under 5 years of age, that behavior should be occurring most days. And for children greater than 5 years, that behavior should occur at least once weekly. Severity can be indicated from mild, moderate to severe. Mild being only present in one setting, moderate being present in 2 settings, and severe, those behaviors are presenting and problematic within 3 or more settings. So, clinical symptoms that would be presenting include things like frequent temper tantrums, excessive arguing with adults, questioning rules, active defiance and refusal to comply with requests and rules from adults, deliberate attempts to annoy or upset people, blaming others for one's own misbehaviors and mistakes, being easily annoyed by others, having frequent anger, having mean or hateful talking when feeling upset, and even spiteful attitudes and revenge seeking. ODD very often precedes development of conduct disorder, and subsequently moving into adulthood, it has risk to develop into antisocial personality disorder. ODD has an average prevalence of about 3.3% of children and adolescents, the range truly being anywhere from 1 to 11% though. It is higher in males than females and most often first presents during preschool years. Rarely does it present any later than early adolescence. It is more prevalent when childcare is disrupted by changing caregivers or when that care is neglectful, harsh, or inconsistent. There are no screening tools specific to diagnosing ODD. It relies heavily upon assessment and analysis of the child's behavior. Some differential diagnoses to consider and rule out include conduct disorder, ADHD, depressive and bipolar disorders, DMDD, IED, intermittent explosive disorder, ID, intellectual disability, language disorder, or even social anxiety disorder, social phobia. ADHD is actually one of the most common comorbid conditions with ODD. These patients also have an increased risk for suicidality, so safety plans and risk assessments are very critical with this patient population. Treatment considerations for ODD include parent management training to help parents learn better how to manage their child's behavior and respond to these behaviors, individual psychotherapy so that the patient themselves can develop more effective anger management skills, family psychotherapy to improve communication and the family dynamics, cognitive problem-solving skill training and therapies to decrease the associated negativity in thought and related anxiety that the patients feel, social skills training to increase flexibility and improve social skills so as to hopefully reduce some of that associated frustration tolerance level with peers, the diminished frustration tolerance level with peers. And medications can be helpful in controlling some of the presenting symptoms in ODD. It's important to keep in mind here, though, that the primary presentation is often during preschool years. So with that very young patient population, most of the time you're going to be utilizing stimulant or non-stimulant options and Risperdal perhaps to reduce aggression when necessary, and at times potentially Prozac to treat the associated mood and anxiety symptoms. Then there's conduct disorder. That's characterized by a pattern of socially unacceptable behaviors. There's 4 different main categories of symptom criteria that could be met. They could include aggression to people and animals, property destruction, theft or deceit, or serious rule violations. It's also possible that these present with limited prosocial emotions, and you could utilize that as a specifier if at least 2 of the following are met over 12 months within multiple relationships and settings. That would be lack of remorse or guilt, callous lack of empathy, unconcerned about performance within school, work, or other activity settings that are important, and a shallow affect. Conduct disorders can also be specified by their time of onset. So there's childhood onset type and adolescent onset type. There's also unspecified. But childhood onset means that one symptom was present prior to 10 years of age. Adolescent onset type is that no symptoms were present prior to age 10. And then unspecified onset of conduct disorder means that criteria is met, but you're unable to determine when age of first onset of symptoms. Risk factors for CD can include male sex, maternal smoking during pregnancy, living in poverty during childhood, parental conditions such as substance use disorders and criminal behavior, exposure to physical or sexual abuse during childhood, or even witnessing domestic violence, family instability, specifically changes in parent or guardian figures, lower cognitive ability, association with peers who are truant from school, utilize substances, or engage in criminal activity, and children who experience harsh discipline have parents with a cruel or rejecting attitude, parents who are in poor health, or parents who do not bring those children to visit with other children. Prevalence rates of CD are higher in males than females. Onset is typically between middle childhood and middle adolescence. Early onset is associated with worse prognosis and increased risks such as criminal behaviors and substance use disorders as children grow and adolescents grow into adulthood. Very few children, alarmingly, receive treatment for their conduct disorder, and roughly 45 to 70% of adolescents with CD go on to develop antisocial personality disorder. Guidelines for treating conduct disorder suggest utilizing medication management to treat comorbid conditions such as ADHD first. Conduct disorder patients, of them 16 to 20% of them have comorbid ADHD diagnoses. They also have comorbid anxiety and substance use disorders commonly. Then psychosocial interventions would be first-line treatment for CD symptoms still persisting even after treating those comorbid conditions. And then medication management for severe aggression or anger that still persists after treating those comorbid conditions would be best treated with Risperdal or valproate. It's important to involve parents, emphasizing parental monitoring of youth activities, enforcing a curfew, monitoring youth social media, discussing rewards, consequences, encouraging structure, and advising parents and youth to spend time together daily. It's also important for providers to remember that dependent on patient encounters or what is shared during appointments. You do have a duty to protect others from danger posed even by children, and you do have a duty to warn and notify law enforcement in certain states. And that is based off of the 1974 Tarasoff decision, and many individuals suggest even if your state does not have a duty to warn or notify law enforcement, there are times in which that is the best course of action and the most ethical course of action to ensure safety. Some other disorders within this category that present during adolescence include kleptomania and pyromania. Kleptomania usually begins during the adolescent years, and pyromania has a strong relationship between fire-setting behaviors in childhood and the development of pyromania, although pyromania as a whole is relatively rare. So you can look further into these two disorders in your DSM. Thanks for following along with this lecture.